Hi, my name is Tom Walker. I'm an associate professor at University of Colorado and a pediatric gastroenterologist at the Children's Hospital, Colorado. It's my pleasure to introduce Dr. Racha Khalaf, who is a senior GI fellow who has done some important work looking at retained gastric button batteries. Racha, welcome.
Thank you, Tom. So today, Dr. Walker and I will be telling you about our mutual study titled Gastric Injury Secondary to Button Battery Ingestion, a Retrospective Multi-Center Review. And in this study, we collaborated with our colleagues over at Cincinnati Children's Hospital, Texas Children's Hospital, and Johns Hopkins All Children's Hospital. And in the study, we performed a retrospective review of all cases of pediatric patients who had a gastric button battery removed endoscopically. And in our chart review, we found 68 patients across these institutions that had removal endoscopically of a gastric button battery. Out of this work, we wanted to define the spectrum of injury associated with button battery ingestions that are found in the stomach, and we wanted to characterize clinical factors associated with gastric mucosal injury. What prompted us to do this work is when we had a case at Children's Hospital, Colorado, of a 9-year-old patient who presented to our ED following ingestion of a button battery. And that patient was then sent home because he was over the recommended age of removal according to both our societal guidelines for pediatric gastroenterology and the Poison Control Center recommendations. Patient represented to our ED 48 hours later and was found to still have the button battery in the stomach, and the button battery had eroded into the gastric mucosa, and it had caused a perforation of the stomach. So upon discussion with our colleagues, we realized that across the United States, people were struggling with decision-making regarding gastric button batteries and whether or not to remove these button batteries, and whether or not the current guidelines were sufficient to help guide our decision points. So to be clear, the National Capital Poison Control Center recommends only removal for symptomatic patients or for patients who co-ingested a battery along with a magnet. Our societal guidelines for pediatric gastroenterology recommend removal or consider removal if the patient is younger than 5 years old, if the button battery is greater than 20 millimeters, and if the battery remains there following 48 hours. So according to these guidelines, our patient that was our index case for the study was properly managed in that the battery was left in place and he presented for care following 48 hours. When we looked at the cohort of 68 patients across our institutions, we found that there was no association between symptoms in these patients and whether or not they had gastric injury. What was significant was that in patients where the battery was removed from the stomach following 12 hours after ingestion, these patients were 4.5 times more likely to have mucosal injury in the stomach than those where the battery was removed earlier. And this goes against what's currently published because age was not a significant factor in our study. It was only timing to battery removal that was significant. In addition, just to reiterate, symptoms as well were not a significant indicator of whether or not the patient had mucosal injury. So whether or not this patient had abdominal pain, whether or not these patients had sternal pain, vomiting, or drooling did not predict whether or not they were going to have mucosal injury. And as we can see from our case, one patient had gastric perforation but had no symptoms at the time of presentation and no symptoms 48 hours later. And so you could have significant injury in the gastric mucosa without any overt symptoms and unrelated to your age. So the takeaway points from our study are that you should consider removal of gastric button batteries within 12 hours of ingestion. in patients regardless of age or symptoms.
So, Rasha, can I ask you a question? Are,
Sure.
are, are you suggesting that that all gastric button batteries in children should be removed?
Our data indicates that these batteries should be removed at the time of presentation. Of course, this is a difficult decision because we don't necessarily know the outcomes of patients who came in and did not have that procedure performed and did not have the battery performed. So of course, more studies are needed. We need better data from prospective studies where we can follow and see what happens to these patients.
And you mentioned this was the largest study of this kind. And despite its limits, how large were other studies looking at this question?
So it's hard because nobody has specifically looked at gastric injury from button batteries in the past. What is available in studies is there are a number of studies where they have looked at injury from button batteries, but they also look at small bowel, they look at the esophagus, and we know that there are much worse outcomes when batteries are lodged in the esophagus. Those patients can have tracheoesophageal fistulas, they can die, and we don't see that degree of severity in the stomach, but there hasn't been any studies really looking at gastric button batteries specifically. So in those studies, the numbers are small.
And do you know what the standard of care, if there is one, is at the other contributing institutions when it comes to retained gastric batteries?
Yep. And so out of our 4 institutions, we know that at Cincinnati Children's Hospital, they have guidelines at their institution, and they remove every button battery that comes in to their institution. And of course, you have to remember that these are large tertiary care centers. So at these 4 institutions, you have at least over 100 pediatric gastroenterologists, and we're not counting the surgeons who are also removing these button batteries. So there's really no truly standard of care across these institutions. It is really left upon the physician to decide whether or not to remove this button battery.
And what do you think are the what do you think are the primary or most important limits of this study?
This is a retrospective study, and in the study we are only looking at cases where the patient underwent endoscopic removal of the button battery. And of course, it depends on who took the call. So when you have such a large number of providers who are in charge of foreign body call, different people will have different preferences and will manage this differently. So we don't know what happens to those patients who did not undergo endoscopic removal and who went home.